Good evening, everyone. Welcome to this webinar entitled Musculoskeletal Real-Time Ultrasound Utilization in a Combined Women's Health and Orthopedic Physical Therapy Approach, presented by Carrie Pagliano and Megan Poll. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand the difference between normal and abnormal pelvic floor ultrasound imaging, discuss pelvic floor muscle dysfunction differential diagnosis and differences noted on ultrasound, discuss how to utilize ultrasound imaging for interventions for pelvic floor dysfunction, and be able to identify when to refer to a pelvic floor specialist based on ultrasound images and clinical exam. As an ACCME accredited provider, it is the AIUM's policy to assure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Carrie Pagliano, Megan Poll, and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenters, you may type them into the question box on the right side of your screen. You will not be able to submit, or you will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of their presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Carrie Pagliano and Megan Poll.
My name is Carrie Pagliano. I'm a physical therapist in Arlington, Virginia, and Megan is joining me as well. We're going to jump ahead, no disclosures, and right on to anatomy, which is where we left off. So just quick references for those of you who aren't familiar with the pelvic floor. The primary aspect of the pelvic floor is going to be basically a hammock between the pubic bone in the front and tailbone in the back. And the picture here is oriented for a female, obviously because there's a uterus, and you have a bladder, uterus, and rectum. This next picture will give both female, actually these are both female views as well, from the deep inner portions of the pelvic floor, also referred to as the pelvic diaphragm. Some of the muscles involved here are levator ani, pubococcygeus, all primary pelvic floor muscles that are important for retaining both urine and stool, important for sexual function and respiration, as well as postural function. This view here is male, we obviously because of the prostate, but just to take reference here on the left-hand side, you see the levator ani is very close to the obturator internus, and the obturator internus being a hip rotator. And Megan's going to speak a little bit about how we can utilize reference points of where the obturator is to get a little bit better understanding of what's the relationship between the pelvic floor and the obturator internus. The obturator internus is also a primary muscle of interest in patients that have bladder issues, quite often urgency frequency or painful bladder syndrome.
So moving on to how we would utilize real-time ultrasound when assessing pelvic floor musculature. You can see in our image here we have a picture of the bladder. The bladder is a fluid-filled structure, so it's going to be anechoic or black on your image. And then you'll see the levator plate underneath the bladder. You'll see a more hyperechoic shadowing underneath the bladder. That's called enhanced through transmission that you see when the sound waves are passed through a structure filled with fluid such as the bladder or a cyst. So when we're looking at this image and we ask our patients to do a pelvic floor contraction, what we're going to assess is there any movement of the bladder or any movement of the levator plate, and do we see the lift? Do we see a depression? Is there an excessive amount of movement? And then we can assess, are they able to cognitively make this contraction, and can this contraction occur automatically without us instructing them? So here is an image that kind of depicts some of the different types of contractions you'll see when asking a patient to perform a pelvic floor contraction. Up top, you'll see a normal levator plate elevation. Over to the next side, you won't see any levator plate elevation. Now that can be a reason either the individual is already pre-contracted, so they can't actually get any more lift, or they don't have the understanding of what you're asking them to do, so they don't actually contract those muscles. You can see an excessive levator plate elevation. You'll see that more often with individuals who might have an organ prolapse. You can also see a more excessive plate elevation in an individual when you're assessing pelvic floor contraction in the standing position. And then you also see a levator plate depression. This occurs commonly with individuals who can actually do a pelvic floor contraction, but due to an increase in intra-abdominal pressure and almost a Valsalva maneuver, you'll see a depression of the bladder, and this can be a neuromuscular control issue, or it can just be a difficulty contracting those muscles and the fascia around that pelvic floor to hold it. So here we have a video of a normal pelvic floor contraction. This view is a transabdominal view, and you can see our nice bladder here. Our levator plate will be underneath here. Again, you see the anechoic bladder and the hyperechoic shadowing that's underneath that fluid-filled structure. And some also might notice as you're looking at the bladder contents, you can actually see some of the fluid moving. Again, if you remember what you're looking through with a transducer, is it's sound waves that are penetrating the tissue, so they can create some bubbling in that fluid and micromotion, so you can actually see the fluid move based on that sound wave. And then here we have a sagittal plane view. Again, you have the bladder, we have the bladder neck, and depending on whether you have a male or female, you can see the uterus and the rectum. And again, you see a nice lift. And now here's an example of a bearing down or a Valsalva type of maneuver. So this would be more of a dysfunctional contraction. So you can actually see that increase in abdominal pressure and that depression of the bladder as you instruct the patient to perform a pelvic floor contraction. So now we're going to move into how a pelvic floor therapist and a general sports orthopedic therapist will utilize ultrasound to assess pelvic floor muscle control and help guide rehab based on what we see on the images. So when looking at an orthopedic patient or a sports patient, you want to have a good differential diagnosis to kind of help guide your treatment and where you need to focus. So a lot of individuals with hip and low back pain, you might see labral tears, femoral acetabular impingement, hip instabilities, SI joint pain, and nerve entrapments. All can have factors related to pelvic floor dysfunction. So it's a very important area to also address when you are seeing these patients with these different hip and low back issues. Do not forget to assess the pelvic floor musculature, assess the ability to contract the pelvic floor, and use that as a tool in your treatment. Additionally, looking at groin-related pain, individuals with a hernia, whether it's an indirect, direct femoral, or even what they would call a sports hernia, adductor tendon injuries, pubic symphysis instability, bone stress, looking at pubic or sacral stress fractures, and osteitis pubis. Clearly, all of these structures relate very closely to the pelvic floor muscles. The fascia of the pelvic floor, the actual pelvic floor, is in communication with a lot of these structures. So again, it's very important to make sure that you're cognizant of that connection when you're doing your general sports orthopedic assessments, and not to forget that even though you don't necessarily have a pelvic floor background, that this is something that could be contributing to their dysfunction. So looking at some of the anatomical relationships and why we care about the pelvic floor muscles from a sports and orthopedic standpoint is that our pelvic floor muscles are very closely related to the posterior hip muscles. So as Carrie mentioned before, the obturator internus, where it's sitting in that fossa, is very closely connected with the pelvic floor muscles and the pelvic floor fascia. So if you have any restrictions in your obturator internus, you probably have some additional issues with some pelvic floor musculature around there. And then looking at our myofascial slings, if you go back to the deep front line and look at where the fascial connections of certain muscles in the lower extremity are, you have your adductor magnus, your pelvic floor muscle, obturator internus fascia, adductor brevis and longus, your psoas, and your pectineus. So again, all of these muscles are common offenders with people who have hip issues, who have low back issues. So these are all interrelated and connected tissue that you want to assess properly. And if you look over at the picture, looking at our bladder here, down here, this is actually an image of your obturator internus. And so you can assess, is there any restriction or connection between the pelvic floor's ability to contract, and is that obturator internus having any type of effect on the quality of your contraction. And then lastly, to keep in mind is nerve entrapments. So your pudendal nerve runs through your sacrospinous and sacrotuberous ligament. It's very closely connected again with that pelvic floor fascia and that fossa where your obturator internus is sitting. So all really important things to think about when you're treating individuals who have any pelvic complaints, whether it's in their groin, whether it's anterior hip, posterior hip, if it's lumbar spine or SI joint related. These are all things that you want to keep in mind when assessing these patients. So here's a video of a obturator internus contraction. So we just have the patient externally rotate their leg, and you can see the fascial connection of that obturator with your pelvic floor. And so you can see just that small kind of depression as that obturator is contracted here. You can see that fascial tissue pulling that bladder over. You might also see with a very hypertonic obturator muscle, as we see in this image here, is a change in even how your bladder looks. So it can even show a difference in the shape of the bladder. So if you put your transducer on this individual and you already see a change in the view of your bladder, you can kind of start to understand, is there a hip rotator component to why they can't contract their pelvic floor properly, and is this something that you can release manually before, say you have to send them to a pelvic floor therapist. So this is looking at our bladder in the sagittal image. You'll generally use your curvilinear probe, that's about 2 megahertz, and just placing your probe above the pubic symphysis and just slightly posterior. And again, you can see the bladder, neck, and then your rectum and uterus if it's a female patient. So in this position, you can do an assessment of pelvic floor contractions, and then you can also transition that into a rehabilitative program where you have individuals contract in different positions, contract under load, contract with functional movements, and so you can assess how well the individual is able to contract those pelvic floor muscles in different uses. The more difficult imaging occurs when you are trying to do a image with an individual standing, or if you're asking them to do an additional movement that requires more global musculature, just making sure that you maintain proper transducer position at all times so you have a very consistent measurement. And here again is our sagittal plane. And then next, our transverse image, again with the 2 megahertz curvilinear probe. The probe is inferior to your umbilicus and angled about 50 to 70 degrees towards your pubic symphysis. In this image, you'll mostly just receive the bladder, and then you get the midline of the pelvic floor muscles. And again, off to the side, you can actually see an obturator internus, and if you externally rotate the hip, you can check to see if you have that in your image. Again, you do your regular assessment, and you can use this imaging tool to help progress your rehab exercises with your patients. And then lastly, as working with patients who have hip, low back, groin injuries, I tend to also image the transverse abdominis. This muscle works very closely with the pelvic floor in creating that proper intra-abdominal pressure when you're doing any loaded task. This you'd want to switch to a linear probe, at least 5 megahertz. The probe would be positioned perpendicular to midline, just above the umbilicus and slightly anterior to the most lateral point. So in this image, you can visualize your transverse abdominis here, your internal oblique, and your external oblique. You also can measure the cross-sectional area of these muscles at a resting and contracted state to help determine where there's some dysfunction, and utilize this in addition to your pelvic floor muscle during your rehab process. So here's a nice contraction where you get that fascial slide and that transverse contraction without a lot of internal oblique carryover. So again, just to reiterate, when treating individuals with low back pain, SI joint pain, or any type of hip dysfunction, there's been numerous research that demonstrates an association with pelvic floor dysfunction, whether it's urinary incontinence or stress incontinence. So looking at that relationship of pelvic floor function, as well as your low back, your hip, and your pelvic or SI joint function is really crucial to getting an optimal outcome with your patients.
All right, so moving over to what we do in pelvic floor physical therapy. The lovely thing about pelvic PT is, and especially integrating real-time ultrasound, is we're able to treat patients all the way from 3 years old, this was my son, all the way up to the elderly, and get information about what's going on in their pelvic floor in a very non-invasive way. And I do want to reiterate that ultrasound imaging is a bit newer and not necessarily in all practices in the States. It's a little bit more dominant in the global community as opposed to biofeedback, but we'll talk a little bit later about what the differences are between the information that you can gain from each source. There are some therapists out there that will look at post-void residual as far as ability to empty the bladder. We're going to focus primarily on the musculoskeletal aspect and the muscular control and coordination in this discussion. So as far as the context of the diagnoses that we're looking at, pelvic floor dysfunction is a really nice broad term to describe any sort of dysfunction in the pelvic floor muscle that could result in symptoms of incontinence, whether it's stress incontinence, which occurs with increased intra-abdominal pressure, urge incontinence, which occurs with a strong urge to have to urinate, fecal incontinence, or loss of gas control. We can also find pelvic floor dysfunction in constipation, pelvic organ prolapse, and predominantly pain as well, which could include diagnoses including dyspareunia, which is painful penetration, and other similar diagnoses including vaginismus, vulvar vestibulitis, and pain associated with endometriosis, interstitial cystitis, and bladder, painful bladder. Other diagnoses we take a look at the abdominals, and those are primarily issues with diastasis recti, postpartum, and also potentially symphysis pubis pain. So for the remainder of the conversation, we're going to be speaking primarily about the pelvic floor. So one of the primary questions that we've really worked on in the pelvic floor physical therapy arena is the Kegel. And historically, when people think pelvic floor PT, and this is referral sources, physicians, as well as the public, is they think if they have a diagnosis of pelvic floor dysfunction, that means they need to do their Kegels. And if they did their Kegels and their symptoms aren't better, then either they didn't do enough of them or they didn't do them correctly. And research recently, I would say more in the last 5 to 8 years, is looked a little bit more closely at the relaxation of the pelvic floor, and that's an area that ultrasound has been really helpful in coordinating with what our digital findings are with our objective examination, really getting a much better sense and being able to relay that information to patients so that they understand that it may not necessarily be all about the Kegel. So the bulk of the literature that's out there refers to pelvic floor muscle training, and there's a lot of variety as to what that includes, but in general, pelvic floor muscle training refers to voluntary contraction and relaxation. And I want to emphasize the relaxation piece because for a muscle to function, it needs to contract and relax. A lot of people, I think, focus primarily on the contraction piece of it, and we do definitely need relaxation for defecation. We need relaxation for urination, and so that's a really important part of what we assess with our physical exam and our ultrasound exam of the pelvic floor. Once you have a good contraction and relaxation, we want to look at integrating that contraction into function, and then the ability to specifically increase strength, endurance, rapidity, and coordination. And so in general, across the literature, this is essentially what's the focus of pelvic floor muscle training. With respect to women with stress urinary incontinence and urge incontinence, women with these diagnoses in pelvic floor muscle training groups are more likely than controls to report a cure and improvement in the literature. They're more satisfied with active treatment. They report less leakage and less frequency and no serious adverse effects. So in general, with respect to pelvic floor muscle training in the literature, there's a positive association with it. Now, that said, there's a little bit of a gap. So looking at conscious contraction of the pelvic floor muscles, there's literature to look at activating the pelvic floor before and during increased abdominal pressure, or more of a bracing mechanism. There's also research that looks at indirect pelvic floor muscle training via the transverse abdominals. And again, with access with ultrasound to look at the abdominals, that's definitely viable. Strength training to increase structural support, elevate the levator plate, and prevent descent during times of increased intra-abdominal pressure. And then the treatment, as a result, here is pelvic floor muscle training, biofeedback, and electrical stimulation. And like I said, this is the bulk of the literature that's out there. The unfortunate thing, if that treatment doesn't work, there isn't a lot to say where to go from there. And that's where we really go back to the concept of understanding, is it really all about the Kegel, or building the case for pelvic floor muscle overactivity? And as Megan mentioned, we really have a lovely opportunity by visualizing the pelvic floor and understanding what a contraction or relaxation looks like, being able to visualize if there's any overactivity of the obturator internus with that indentation towards the bladder, what the normal muscular strategy is for the muscles in this region. So overactive muscles are muscles that do not relax, and they may even contract when relaxation is functionally needed. And quite often the diagnosis that we find overactivity in dyspareunia, so that would be any of your painful penetration or painful intercourse, any sort of obstructive defecation, so potentially constipation or other voiding problems. And in this particular situation, if that's what the problem is, Kegels would be the opposite of what's indicated. So it isn't necessarily all about the contraction, but we need to go back to the true definition of pelvic floor muscle training, which is the contraction and the associated relaxation. Now, if we take a look at this from an abdominal pressure standpoint, we're looking at pressure coming from above and maintaining that, and also the pelvic floor supporting from below. So we want to look at where there's overactivity and underactivity. So if we look at the abdominal canister, so to speak, we've got the diaphragm from above and the pelvic floor below. We've got the abdominals anteriorly and the lumbar paraspinals and deep back musculature posteriorly. And ideally that pressure is contained quite nicely. If you have areas of overactivity, it's going to translate the pressure elsewhere. If you have potentially gaps in that system, like you may have with a diastasis, that could influence the pressure as well. If you have patients with inefficient breath patterns, that can influence pressure translation. So as a physical therapist, we're not necessarily primarily focused on what's going on only with the pelvic floor when we're looking at these patients with pelvic floor, or the diagnosis of pelvic floor dysfunction, but we want to take a look at the pelvic floor not only as a muscle of continence and posture and support, but also as a respiratory muscle. So because of the pressure translation, when you take a breath in and we get that eccentric elongation of the diaphragm, we also get a inferior translation of the pelvic floor just slightly, and then with the exhale, as the diaphragm rises, the pelvic floor will translate superiorly as well. So we have a nice little small superior inferior motion that goes along with that. And if we have patients that do have overactivity of the pelvic floor, this can be a great mechanism not only to assess, like Megan mentioned, we can take a look at breath patterns and do we have movement of the pelvic floor, but we can use breathing, which we do 21,000 times a day to access the pelvic floor and change breath patterns throughout the day to potentially get an influence on that overactivity. So this is just a quick video to take a look at what happens from the diaphragm. Unfortunately, the video didn't translate down towards the pelvic floor, but again, as you take a breath in, that diaphragm is descending and we get that inferior translation. So remembering that our organs move, and as we take a breath in, there is pressure that translates towards that pelvic floor, and we get that eccentric elongation and that concentric shortening. So our treatment is dependent on our clinical hypothesis, and a lot of that is based upon the information that we gain in our assessment. So with an overactive pelvic floor, we have incomplete relaxation. So the treatment here is going to be focused on down training, addressing movement strategies, postural, potential neurological input, looking at breath strategies, with the goal that we're going to integrate into general function for ADLs, progress to coordination, strength, and endurance. Whereas an underactive pelvic floor, the goal will be to uptrain and want to identify issues that might be contributing to that, but also work on coordination, strength, and endurance. So where ultrasound can be very helpful for us is getting a much better sense of how the pelvic floor is functioning as a whole, with breath, with activity of the surrounding muscles, including the hip musculature, and also use it to assess what's going on with the abdominals. So what does this all mean now that we understand a little bit more about overactivity and that we're not just focusing on a contraction? What does this mean in the context of an ultrasound examination and treatment for those of us in pelvic floor rehabilitation? So as Megan mentioned, potential findings for overactivity, if we just look at resting breath, ideally we're looking for movement of the pelvic floor, but we may not find it. And with a contraction, we may not find movement at all. And the hard thing initially is to confirm that the patient is able to understand what the directions are cognitively, but also that they're not performing a paradoxical contraction. So they're contracting when you're asking them to relax, and vice versa. What you also might see is a minimal lift. So if you have a patient that already is in a bit of overactivity, if you ask them to contract, they may not actually have much more to do. They may not have any more excursion to go. Again, there may be some issues within coordination and then performing a Valsalva when you're asking them to perform a contraction. So these are all potential findings with pelvic floor muscle overactivity. And again, as a reminder, the diagnoses that we're looking at from a pain perspective, they may be painful intercourse, it may be urgency frequency of urination, it may be constipation. Now, for underactivity, we may or may not see movement of the pelvic floor during a resting breath. And again, we may see similar findings. We may not see any movement, we may see minimal lift, we may see excessive movement and coordination and so on. So you might ask, well, if the findings are similar, how do you know one versus the other? And that's really where you have to pull together that entire clinical picture and coordinate just with any other imaging. The imaging findings have to correlate with what the patient's subjective has revealed and any other findings that you have. So imaging alone doesn't necessarily, in this particular case, give us the full picture. We need to coordinate it with the rest of the exam. So from a big picture perspective, we're looking at intra-abdominal pressure control, we're looking at breath, posture and alignment, hip and spine contributions, as Megan mentioned, the neurological system that could result in overactivity of muscles, and movement. Whereas locally, we're going to assess the pelvic floor via palpation, whether that be external or internal, depending on the patient population. Utilizing real-time ultrasound imaging to help decide from whether we're dealing with overactive or underactive muscles, looking at the contraction and relaxation capabilities. We're also considering tissue integrity. Are there any genetic or hormone components that might influence the integrity of the tissue? If the patient is postpartum, what the hiatus distance is, if there's a large hiatus, is that affecting the contractile capabilities and the stiffness and support of the pelvic floor? And then coordination. So the last thing we finally get to as we're looking locally is that strength or endurance piece, or that Kegel piece. So we get there eventually, but lots of times why patients don't necessarily get better with doing Kegels on their own is because they haven't had a good, clear hypothesis or a good reason that really focuses on what the problem is. So getting to Kegels eventually and integrating into function is great. It just needs to be integrated at the proper time. So typical pelvic floor muscle therapists that do internal muscle examinations, it's a little bit different from a gynecological exam because it's just one or two fingers as opposed to a bimanual exam. Okay, we're palpating for superficial and deep muscle fibers. We'll take a look at a cognitive contraction. We may have a patient do a strong contraction. We may have them do a cough. We may have them bear down to push, to attempt to push out a bowel movement. The difficulty here is we do have a sense of what the function is and the ability to contract and relax, but we do not have a sense of what the translation of that muscle function is to the bladder. And that's where ultrasound can be really a nice, efficient way that you may feel a great contraction manually, but if you take a look at it on ultrasound, your patient with stress incontinence, when they're running, may not have any sort of translation of that pelvic floor muscle contraction to the bladder at all. So with real-time ultrasound, we're able to see the activation, we're able to see the lift of the bladder and the timing with the TA. We're also able to see with the integration with the diaphragm. And as Megan mentioned as well, we're able to do a nice functional neuroeducation progression, integrating alignment and movement integration. So the muscle exam, again, we take a look at the superficial and the deep muscles of the pelvic floor. We're able to palpate that obturator internus that Megan highlighted. So if we do have patients with hip dysfunction, and quite often patients, I think more recently in the last 5 to 7 years or so, patients with FAI surgery or labral surgery may have an increased incidence of pelvic floor dysfunction, partially because of that relationship so closely between the hip rotators and the pelvic floor musculature. We're also able to assess strength and coordination digitally as well. Now, historically in pelvic floor muscle training, biofeedback has been the gold standard, and there is quite a bit of difference between biofeedback and ultrasound. Biofeedback, you're either using an internal vaginal probe or external sticky electrodes, and you don't have the specificity that you do with the ultrasound. You have a general sense of what's going on with the muscle activity in that area, and it's very easy to have incorrect readings. quite often the electrode, if you have a high-low table that's plugged into the wall as your treatment table, if it's not unplugged, you may get the electric activity that registers on the electrode, and sometimes as well you have problems with patients being able to get the electrode in or even retain it. So if you're trying to look at muscle activity for a patient in standing and their hiatus or their introitus is too large, that internal electrode may just fall right on the ground. It's difficult to use in function. It's actually very difficult and very painful to use an internal electrode in sitting, and that's vaginally or rectally, and quite often sitting it's a little bit easier to do the external electrodes. But there are some home units that are coming out now that show a little bit more promise with greater specificity and ability to sense not only the contraction but the relaxation piece. Now, real-time ultrasound, we are also getting a great form of visual feedback. So if you have those patients that really want to have a good sense of what's going on with their body and that lift, they can really see that with the pelvic floor contraction and relaxation, visualizing. And again, primarily we're talking a transabdominal approach here. You're able to get greater functional specificity and actually get good information whether the bladder is actually being supported with a pelvic floor muscle contraction, and to see what happens not only automatically but with cognitive contraction. And we're also able to use it with other muscles, including the abdominals, pelvic floor, and back. So where we're finishing up here is when to refer to a pelvic floor PT. And Megan and I used to work together in a hospital-based clinic and really had a lovely relationship in which it was very easy for us to share patients that might need a pelvic floor consult. And she was able to highlight as well, if she's able to look in ultrasound and find muscles that may not necessarily be contracting or relaxing in the way in which she anticipated, that's correlating with her findings and the patient's subjective complaints, and she wasn't able to address it with breath or external treatment, it was very easy for her to take her findings and come to me and say, I'm seeing this on ultrasound, this is what we're seeing externally, this person may need an internal consult. So we were really able to reserve local treatment and internal assessment for those patients that she was able to really isolate that they primarily had a pelvic floor problem that required local internal treatment, and she was able to focus on more the external aspect of it and the spine and pelvic piece to it. So the times when to refer to a pelvic floor PT, if you do have musculoskeletal ultrasound imaging access and the techniques that you typically would utilize are not allowing or not promoting change in the function of the pelvic floor that you're looking for, make sure that you ask those questions. Are they having pain with intercourse? Are they having any loss of control of bowel or bladder, or urgency or frequency? And getting used to asking those questions and making it very normal and comfortable both for you and your patient. And if you don't know where to find a pelvic floor PT in your area, we'll post some references at the end. So in summary, real-time ultrasound can be used to give additional information to clinicians regarding muscle activity related to the bladder, and can be very beneficial as a form of visual feedback both for the patient and the clinician with respect to pelvic floor muscle training. It should be used in conjunction with clinical picture, including both internal and external pelvic floor muscle examination, and in conjunction with a patient's subjective findings. So I would like to thank the Women's Health section of the American Physical Therapy Association, as well as the American Physical Therapy Association and AIUM for inviting us for this webinar. If you do need to find a pelvic floor physical therapist in your area, you can go on the web at womenshealthapta.org on the PT locator, put in your zip code, and you'll be able to find physical therapists that are able to treat pelvic floor dysfunction. And be aware that not all pelvic PTs do have access to musculoskeletal imaging, but it is becoming more relevant and more introduced in our physical therapy curriculums with our students.
Okay, so if there's any questions, Carrie, can you see any of the questions on your screen?
We are looking right now.
If not, I can read them to you.
let's see if we can do this. How did you go about getting your ultrasound training? That's a great question. Both Megan and I were actually fortunate enough that one of the therapists that we worked with used or basically was introduced to it and trained in Australia, and when he came to our clinic, brought that training to us. So we were entirely fortunate that we had in-house training. Megan, I don't know if you had any additional comments there.
I think I've also done a lot of training outside of the personal mentorship I received from my colleague. The AIUM has a lot of great resources. There are several courses that are more geared towards physician-based ultrasound training. It depends on whether or not you want a course that's more rehabilitation focused versus diagnostic ultrasound. So it's just a matter of knowing what you're looking for in terms of getting ultrasound training and then finding the right sources that can provide that for you.
And I think once you do find that training, the most important thing is to just keep practicing. It's not something that in PT school we're used to looking at those images, and it's just practice, practice, practice. The next question is, what is the age range in which you see pelvic floor dysfunction, in which ultrasound and PT has been helpful? And that's from Doug White. Doug, one of the nicest things about ultrasound, and I'm starting to treat more pediatric incontinence at this point, is I'm able to get a good amount of information from younger patients that may not necessarily be able to verbalize what's going on. And so the age range may be from when kids should be potty trained, so we're talking, age 4 or 5 years old, and they like to see what's in their bodies because they think it's cool, all the way up to, gosh, I mean, I see patients that may not have ever had any sort of vaginal penetration or used tampons or things like that, so the idea of a vaginal exam is terrifying to them. So ultrasound, especially in the pelvic pain population, is a remarkable way to start to introduce them to a part of the body that is very foreign. And then another population that's fantastic that I'm starting to work with a bit more is the immediate postpartum population. In the United States, we don't do a great job at getting postpartum physical therapy right off the bat, whereas in Europe, there's quite a few countries that there's mandatory PT for 6 weeks immediately postpartum. So using ultrasound, especially within those first 6 weeks after delivery, patients are hesitant quite often to do a vaginal exam until they have their follow-up with their physician, which is fine. Ultrasound will give us some idea as to what's going on with the pelvic floor function, because you're still using the pelvic floor during that time, and it's a nice opportunity to start to train some gentle contraction and relaxation. So the short answer is really any age can be quite helpful.
I think also looking at it from more of an orthopedic or sports standpoint, any of your athletes, whether they're male or female, who come in with hip dysfunction or low back pain, it's always a great assessment to see what the pelvic floor is doing, see what their transversus is doing. So any active population who you wouldn't necessarily think they have a pelvic floor dysfunction, it's an easy tool to assess those muscles, and it's really helpful when you find those dysfunctions to help progress your treatment.
And I think to build on that piece too, especially therapists that may not be as comfortable assessing the pelvic floor, this provides a really neutral way to look at it and start to ask those questions and look at that area without necessarily having to dive down the rabbit hole of being a pelvic floor PT. So making sure that they're including it in their assessment, including it in part of the body, but not necessarily having to go full on and be trained in internals. The next question is from Megan Sovey. Do you find insurance covers real-time ultrasound? And we get that question quite a lot. It's interesting. It's very similar to, I think we quite often use neuroreeducation to basically cover the reasoning behind what we're doing. But for those that are in pelvic floor PT, most insurances don't cover biofeedback. So if you're going to do biofeedback, you're going to do the same coding anyway. So typically it's not going to be a procedure code. It's going to be like a neuromuscular reeducation.
And next, when would you decide they might benefit by real-time ultrasound therapy? I think that the big message that we're trying to send here is real-time ultrasound is just a tool that you can use to further enhance the treatment and assessment that you're providing your patients. It gives you that extra bit of information that you wouldn't have from a clinical exam and your manual exam. And it also gives you a visual and your patient a visual of what is going on and what you're asking them to do. So I think, you know, there's never a time where a real-time ultrasound in this setting isn't beneficial.
And I would agree. I mean, I typically will use it in my initial assessment, which becomes patient education. And I've had a really fun time alternating back and forth. Some patients I may do an internal assessment first and then follow it up with ultrasound and see if I can correlate the findings, and sometimes I might swap it if I have a patient that may not necessarily tolerate the internal exam or be interested in that. Getting information to them via ultrasound might be my gateway into getting them to buy into understanding what's going on with the pelvic floor. So I think my answer is very simple in that I don't think there's a time that I wouldn't use it. Okay, have you ever treated ED? And so we're referring to that as erectile dysfunction. There are some patients that do. I will admit my bias. I'm primarily a women's health therapist. I did treat some male pre and post prostate patients for quite a while. And that's actually a fantastic area. There's some wonderful research with Paul Hodges on using verbal cueing and using some ultrasound imaging to get good localized activation of the pelvic floor. With respect to utilizing it for erectile dysfunction, I think it depends on what the hypothesis is as to why there is erectile dysfunction. So if it's a potential muscular or neurological issue that would require assessment of the pelvic floor, then sure, I think ultrasound would be beneficial for that. If there's some other reason that's different, wouldn't necessarily require that, then no, I wouldn't use it.
Next question, how much are unit applicable for MSK ultrasound for transabdominal and transperineal transducers? Not quite sure what the question is asking specifically. If you're asking what's the cost for a unit to use in the clinic, there's a wide range of costs and individual companies that provide these types of units. If you're in a smaller clinic, you're probably going to look for a portable unit. They also make tablets now that come with curvilinear and linear probes. And again, the price can range from $4,000 to over $100,000 depending on the type of unit you're looking for. The images and the application that we're kind of discussing today, you could err on the lower end because you're not looking for great structural definition as you would for more of a diagnostic ultrasound exam. So you can get away with using a less sensitive unit and it would come at a cheaper price.
Oh, hi, Adrian. I often use real-time ultrasound to assess stability during alternate straight leg raise or active straight leg raise, sorry. Can either of you comment on this? Thank you, Adrian. I think, you know, Adrian, if you're referring, I'm not sure if you're looking for pelvic floor or transverse abdominal, I think you can do that. I don't see why not. I specifically don't. But I think it depends on the population that I'm looking for. If I'm suspecting, asymmetrical dysfunction, then I would definitely use ultrasound to focus on that a little bit more so. But specifically for that thing, I think it just depends on how you go about that assessment of your patient. So I don't know if that answered your question or not, but I don't see why you couldn't.
I know there's several research papers that have shown validity of measuring pelvic floor muscle activation doing a active straight leg raise. It's a good assessment from an orthopedic standpoint to determine, can these muscles activate voluntarily, and are the patients, having difficulty cognitively contracting when you have them purposefully make or try and contract versus when you have them do a different activity where they're not as cognitively aware, and does that pelvic floor contract or does your transversus contract? So it gives you information on involuntary and voluntary contraction capabilities of the muscle as well.
Sorry, Adrian, I totally lied. I misread the question. Yes, I actually do that now that Megan's spoken. So lots of times I will do that, just a quick assessment just to get a sense of automatically what they will be doing, primarily with TA. Sometimes with pelvic floor, but lots of times if they have overactivity of internal obliques, I may get the probe pushed out a little bit, so I may not get a clear reading. So I apologize. The answer is yes. Okay, are there limitations for ultrasound assessment of the pelvic floor muscles? For example, large body or massive large prostate in males? I would say, especially the transabdominal approach with women, a lot of the issues that I run into may be a larger patient, but also if they'd have a lot of abdominal surgeries. Sometimes if they've had multiple cesarean sections and you have a lot of scar tissue, immediately superior to the symphysis where you're positioning that that transducer, it may make for an image that's not beneficial, and it may be something that you get a little bit of information out, but it may not translate well enough to the patient for it to make a difference for them from a feedback perspective. I think the other limitation, you obviously, to have a good sense of what's going on, it's nice to have a good full bladder, and you may have those patients that they come in and they have gone to the bathroom immediately before their evaluation because they think you're going to do a pelvic floor exam, and so you're not able to assess without giving them a couple of cups of water. So the limitations there would be, I think, the patient.
Is there a clinical role for transperineal ultrasound, or does transabdominal offer sufficient information or under overactivity? Question 2, transabdominal is a great objective measurement for, and question is cut off.
Oh, there we go. Fast twitch and slow.
Great objective measurement for fast twitch and slow twitch pelvic floor activity.
Hey, Gerard, how are you? So there, I think a lot more of the research is focusing a bit more on the transperineal, and especially I would say in the male, and you would probably know that quite well. Paul Hodge's research has again really focused on kind of that urethral closure mechanism and those verbal cues that really focus on that. I think as we get some more research on females, we're really going to be focusing much more on the transperineal approach as well. From a just a clear logistics perspective, the primary issue that a lot of PTs may have from a transabdominal approach versus a transperineal approach might be one of actually just infection control and making sure that transabdominal is just entirely much easier for infection control as opposed to transperineal. And especially if you have a department where you're sharing that unit with multiple other clinicians. Transabdominal, I think it's a great gateway drug to ultrasound, but I do think that from a research perspective and from a specificity perspective, and especially with males, transperineal is where it's at. But thank you, Gerard.
Okay, and that will conclude the webinar. So thank you very much for our presenters, and on behalf of the AIUM and APTA, our thanks to all of you who participated in tonight's webinar. Please remember to complete the post-test and the activity evaluation. And we hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.